Wondering how to taper prednisone for PMR? I'm Dr. Megan, the prednisone pharmacist, and I got lots of questions from people wondering how to taper off prednisone if you're taking it for polymyalgia rheumatica. Now, this is specific for this disease, but a lot of what I'm going to say is applicable to anyone taking prednisone for any disease because it's the principles of the drug itself. But there are a few nuances about PMR specifically that I wanted to touch on because there are so many people on prednisone for PMR for so long. So you have unique challenges that I want to help you overcome right now. And I've had several prednisone warriors reach out and tell me their story. So I want to incorporate some of their stories as well. I did a long interview with a woman named Diane who has PMR, and her story is really helpful. And another woman responded to that with some tips for maybe what Diane could have done differently. So I wanted to share that. So generally, PMR, polymyalgia rheumatica, is a condition of inflammation and pain in the shoulder and pelvic girdle area. Other joints can be affected, but those are the main places, leading to an inability to lift a cup to your mouth, latch your own bra, all sorts of miserable consequences from incredible shoulder pain. And it usually happens to women over the age of 50 of Northern European descent. That's the stereotypical person, although it can happen in men and it can happen in other populations, but the most common are basically white women. So you might first wonder, okay, I've got this diagnosis of PMR. How long am I going to be on this? It's just a month, right? No, unfortunately. That's what I thought for my condition too. I thought, oh, it'll just be like 10 days and then I'll be off. No, it was 9 months for me. For my condition, which is not PMR, mine's called ITP. But for PMR, they've done several studies and this is one of them. It says the mean duration of steroid treatment for all patients was 30 months with a range of 13 to 108 months. So that could be about a year if you're lucky, or it sounds like one of those was on it for almost 10 years. Every person's different. They said the higher the ESR and CRP on diagnosis, those are blood tests that show inflammation. ESR stands for erythrocyte sedimentation rate, and CRP stands for C-reactive protein. The higher those were, generally in this study, the longer the duration of prednisone treatment. So that's a really interesting association to see that basically the more inflammation you have, the longer you're going to need an anti-inflammatory medication like prednisone. It makes sense. And so with that, about how many people? So I saw one study that showed about half of people, this is a different study, half of people are on prednisone for a year. Another half of those are on prednisone for 2 years, and another half of those are on prednisone for 3 or more. So basically, it's a half-life of 1 year, if you know how half-lives work. But the prednisone itself has a half-life of 2 hours. So this is really helpful to know that this is a very long-term plan. Your next question might be, when is prednisone going to kick in? And one study showed a woman responded after 12 hours of treatment. Other people have said 2 to 4 days. Another have said within 2 weeks, you should definitely have a response. And if you're still having pain after that long, maybe the dose isn't enough. What dose would you normally take? Somewhere between 15 and 25 is what the guidelines say is where the doctor should start your dose. But everybody's unique and everybody has a dose that is going to work for them. And your goal is to find whatever that dose is that is the lowest effective dose. So you could start out at 25, but then you'd want to drop until you get to a point where maybe the pain's coming back. And then you go back up to wherever that dose is not causing pain for you. So it's somewhere between 15 and 25. For some people who have other inflammatory complications, like for example, if you have giant cell arteritis overlaid with it, giant cell arteritis acronym is GCA, and there's a higher percentage of people who have GCA and PMR. They're correlated. Sometimes PMR can lead to GCA, sometimes GCA can lead to PMR. There's an overlap in the type of person who gets these diseases. And so if you originally come in for PMR and you actually might have underlying GCA that isn't treated, maybe you actually need a higher dose to overcome that more inflammatory condition. And just what GCA is, it's inflammation of the arteries, typically the arteries here, and it's called temporal arteritis. And it's painful, can lead to headaches, vision loss. And so doctors are very aggressive in treating it with pretty high doses, usually somewhere between 40 and 60 milligrams for that disease. So if you're not getting pain relief from your PMR, maybe you need to go up in a dose. And always, everything I'm telling you is working with your doctor closely. I do not replace your doctor. You definitely need to be in close communication with either your rheumatologist, if that's the person treating you, or your primary care doctor. And while we're talking about doctors, it's really important that you get the accurate diagnosis. PMR is kind of a diagnosis of exclusion, making sure it's not other things first. You wouldn't jump straight to a diagnosis of PMR without a blood test, without ruling out rheumatoid arthritis and several other things. So you'd want to make sure that if you're in any doubt whether this is your diagnosis, like if the prednisone isn't working, then get a second opinion. Like, do not hesitate to get a second opinion, because if it truly is PMR, typically prednisone works miraculously. Like, you're in agonizing pain and then suddenly the prednisone kicks in and you have relief. You're able to function again. You have energy. You have enthusiasm for life at first. So definitely get a second opinion if this isn't working for you. Okay, so now at this point, you have found the dose that is working for you, the lowest effective dose that is helping. You're getting the pain relief. And the reason we want it to be the lowest effective dose is because prednisone comes with lots of side effects. I'm talking more than any other drug. A professor at Harvard, where I learned about PMR and GCA and other forms of vasculitis, he said that prednisone and other steroids are the best drugs in rheumatology because they work so miraculously. And they're the worst drugs in rheumatology because they're so horrific in the side effects that there's nobody who wants a person off prednisone more than their doctor, aside from the patient itself, because the patients, we are the ones experiencing the horrific side effects. And the doctor knows that there are so many terrible possible consequences. So what are these consequences the doctors are worried about? Well, it's anything from head to toe. Check out this image of my side effects. It can be anything from mood changes like anxiety, psychosis, depression, to heart disease, stroke, heart attack, arrhythmias, bone issues, whether it's bone loss, osteoporosis, or osteonecrosis, bone death, diabetes, high blood sugar, weight gain, all sorts of metabolic complications, insomnia, and on and on. So many possible changes that you definitely want to minimize by getting on the lowest effective dose for you. You don't want to go below that, otherwise your disease flares and the inflammation gets worse. You want to find precisely where your disease is under control and you're minimizing your risk for these side effects. So now that you've figured out what that lowest effective dose is for you, what is the plan from here? Well, working with your doctor, you could do some of the following things. You would want to find a way that the drug is working at the best time of day for you. So typically, PMR has the worst pain in the shoulders upon waking. And so you'd basically want to figure out a way that the drug works when you're waking up. And there are several strategies of how to do that. You could take prednisone like most people do with other diseases first thing in the morning to mimic cortisol. That is what most people do for other diseases, but not necessarily for PMR. Because PMR has that early morning pain, some people change the way it's dosed. And instead of taking it first thing in the morning only, they may also take a bedtime or a middle of the night dose. So let me read the story that I alluded to earlier. This was the response of how this woman had figured out how to get to the lowest effective dose using an interesting dosing timing. So I'm going to just read her story. I suffered for many weeks with my husband helping me to get out of bed before a very astute physician knew exactly what it was. Started at 10 milligrams of prednisone, then was up to 15 milligrams 2 weeks later, and that controlled my pain. During those 2 weeks, I tried various dosing times. Initially at breakfast as recommended, but the pain started returning by bedtime. And then the breakfast dose took a while to give some relief. The typical dosing with prednisone does not take into account the morning pain with PMR. Dosing at night helped me to go to bed without pain, so it didn't build up overnight and completely stopped the morning pain, but I didn't sleep. After doing a lot of online research of medical reports, I found several studies and articles talking about their circadian rhythm. Suggested dosing in the middle of the night for PMR specifically because of the morning pain. And she's quoting a study now. The body normally produces cortisol between 2 and 3 a.m., which can then counter the cytokines that are produced between 4 and 4:30 a.m. One study compared the dosing at 2 a.m. versus 6:30 a.m. and found there was much less morning pain with the 2 a.m. dose. And another study, not in PMR, but in rheumatoid arthritis, showed that administration of low doses of prednisolone, 5 or 7.5 milligrams daily at 2 a.m. had favorable effects on the duration of morning stiffness, joint pain, and morning serum concentrations of IL-6. That's an inflammatory marker. She continues, that worked well, but I would start again with some shoulder pain at supper time because the early morning dose had worn off. Doing a split dose, as suggested in a PMR forum, was my answer. 10 milligrams at 2 a.m. and 5 milligrams at 6 p.m. I could sleep well until my dose, had a tolerable amount of sleep disturbance after that, and awakened with no pain. After 1 month at 15 milligrams and finally seeing a rheumatologist, he started my tapering by 2.5 milligrams every 2 weeks until I hit 10 milligrams, then by 1 milligram monthly. I gradually reduced both splits until I was down to 8 milligrams in a single dose at 2 a.m. Even 2:30 or 3 a.m. was okay, giving me better sleep for a bit longer each night. Like Diane, I found I had to listen to my body. I needed to go down very gradually by 0.5 milligrams the first week of each month, then could finish the month at the desired target dose. This last taper to 6 milligrams was further complicated by the time change, but I have been okay now finishing the month. Each month now will be a new experience. I loved this story because it showed a lot of principles of PMR, tapering, and dosing. So she talked about the split dosing that I mentioned that it's got a 2-hour half-life. So it's basically completely gone after 12 hours. So if she's taking it at 2 a.m., by the evening, it's pretty much gone. And so she needed just a little bit more. I'm not saying you need to follow her strategy, but she did say you need to listen to your own body. And I fully agree with that. Every single person with PMR is different in how long they're going to be on it and what dose works for them and their inflammation and pain. I also appreciated how she described her relationship with her rheumatologist. She finally got to see them because rheumatologists are often booked out really far in advance. And the way that rheumatologist tapered the prednisone was exactly what is recommended, not only by the Harvard professors that I learned from, but also by the guidelines written by the European League Against Rheumatism and the American College of Rheumatology. And that is that before 10 milligrams, you can taper by about 2.5 milligrams a week. So for example, if you were to start at 15 milligrams, the next time you drop, you could drop to 12.5 milligrams. And potentially the next time you could drop to 10 milligrams. But at that point, you do not continue dropping by 2.5 milligrams. That is way too much of a dose drop. And that is because the drop is more important that we consider the percentage drop instead of the actual milligram drop. When you're dropping from 12 to 10, that's about, 2 milligrams is about somewhere between 10 to 20%. And that's the goal we want to go for. But when you drop from that, the same 12.5 to 10 is 2.5 milligram drop. And then if you were to go from 10 to 7.5, that 2.5 milligram drop is actually 25%. That's actually twice, like a humongous drop. percentage-wise. You want to keep it lower, between 10 to 20% when you're dropping. Especially with PMR, she was mentioning she was only being able to drop by a half of a milligram, so 0.5. And that's pretty common as well. So some people can tolerate a drop from 10 to 9, 9 to 8, 8 to 7, and so on with PMR. Others have to drop by a half a milligram at a time. And each of those drops is over a month. And there are several ways we can do that. So let's talk about ways to drop. So you could just drop straight from 10 to 9, and just one day you were taking 10, and the next day and thereafter you take 9 milligrams. Some people can tolerate that. Other people have to be a little bit more nuanced. And that's where every other day dosing comes in, or every few days. So that's where you might go from 10 on day 1 to 9 on day 2, 10 on day 3, 9 on day 4, 10 on day 5, whatever number we're at. But every other day, you're going back and forth from old dose to new dose, old dose, new dose, old dose, new dose. And you just do that for as long as needed until you're tolerating that drop. Because essentially when you're doing it like that, that's basically a half a milligram a day, right? When you average it over 48 hours, you're only dropping a half a milligram. So that's a possibility. Other people have to extend that even further. Instead of every other day, it's every few days. So it would be old dose, new dose, old dose, old dose, old dose, new dose, old dose, old dose. It would be like every 3 days or something. And then you can make it even smaller and smaller as time goes on, the timing between it. There's an amazing resource that has many different tapering schedules on it, strategies that have been mentioned in guidelines and in support groups. And I'll have a link to that in the notes for this video, of this taper resource that you can just plug in what dose you're on, and it can spit out a schedule for you using one of the built-in taper plans that others have put into their system. So that's another strategy if this is a little bit too complicated for you. And then in order to be dropping by, from 10 to 9, you do need access to 5 milligram tablets, or 2.5 milligram tablets, or 1 milligram tablets. Essentially, you really have to have access to 1 milligram tablets. And can you split these in half? Yes. So you could technically take 9.5 tablets if you wanted. You would take like a 5 milligram tablet, and then 4 1 milligram tablets, and then a half 1 milligram tablet. You could do that. That's a possibility. Or you can do that alternate day dosing. Working with your doctor and listening to your body are the really most important keys here. And I am available for consultations if you absolutely need it and you've exhausted all the resources you already have. I'll have a link below to that as well. I can consult on what you can discuss with your doctor. So in addition, I have a free prednisone taper chart. And I have that extended taper that's over a year that you can refer to as a possibility for how to taper prednisone. It's got short-term tapers, longer-term tapers, and the longest-term taper. And it includes that every other day dosing. So you know exactly what to do. You can just, mark things off as you get them done, every dose that you take. It's free, it's printable. Just click the link below to download that now. And how do you know if it's your disease flaring, or you're sick, or you're in prednisone withdrawal? And that's a super tricky question. And I asked it to the professors at Harvard, and they didn't really have a great answer. But crowdsourcing it, I got some answers. And I think what one person suggested, and it's, do I watch CRP levels, watch pain levels? I think the combination of listening to your body, watching your pain levels, and potentially getting blood draws to see if your inflammatory markers are going up, your CRP or your ESR. And if they are, then clearly that's your disease flaring and you're not going into withdrawal. But if you're just feeling yucky and you're not getting that pain and it's just a blah feeling, low energy, that's probably more likely withdrawal. The treatment for either of them is the same. Go back to the lowest effective dose where you weren't feeling yucky, where you weren't having pain. And then start again to taper at a much slower rate after totally stabilizing. Never try dropping a dose if your pain isn't totally under control. There's no point in trying to fight it. you're not going to win. The inflammation is too dramatic to try to push it. And so if tapering that long sounds horrendous to you, and being on prednisone sounds horrific to you for that many years, luckily, in the last few years, they've recently come out with some alternative medications to prednisone, or supportive medications, what they call steroid sparing, allowing you to get on a lower dose of prednisone. And these include Actemra, which generic name is tocilizumab, and Kevzara. And there are a few more under investigation that may help. I've made other videos all about these, so you should check those out. But essentially, talk to your doctor about getting on these biologic injectable medications if prednisone is so intolerable to you. Because for me, it was intolerable. And for many people, it is definitely intolerable. One study of giant cell arteritis showed that the lowest effective dose on average was 9 milligrams. But the dose where the side effects were tolerable was 5 milligrams. There was literally no golden dose where the benefits outweighed the risks. It just fails so often. It doesn't actually keep people out of remission with giant cell arteritis. And so finding that balance is a really tricky question and may be impossible to find. And so luckily we have these injectable biologics that can help some people, not everybody, but at least for most people, they allow you to get on a lower dose of prednisone. So talk to your doctor about that. And again, if you need help tapering prednisone, click the link below to download my prednisone taper chart. Signing off as Dr. Megan, your prednisone pharmacist.